meeting, and you'll be able to access it later on in that way. And feel free to turn off your videos or whatever works best for you. Furthermore, Dr. Fontaine is open to questions throughout her presentation. I just ask that you put them in the chat so that we can moderate and ask them as we go along in a way that makes sense with the presentation. So without further ado, I will let Dr. Fontaine go ahead and start presenting.
Okay, thanks, Alyssa. All right, you guys, thank you so much for setting this up. I'm going to be talking about a variety of issues this evening, but really with the goal of getting to what I think people are most interested in, and that is, how do you work your way into a career path with the federal government, if that's something that you're interested in doing. And the bottom line is that there are many, many ways to end up in a career with the federal government, and we'll talk about some of those. And of course, yes, I am open to questions as we go. Okay, so first I want to let you know that I'm going to share some opinions this evening on my own views of the pros and cons of working for the federal government. My opinions do not represent the position of the DoD, the Army, or the PCBH program, or DHA. So I want to make sure that I am clear that my opinions are my own. I am going to share a number of both positive and negative viewpoints because I am a very pragmatic, honest, and clear-spoken person, and I tend to just give it all to you so that you can then make some really well-informed decisions for yourself as you move forward. Okay, so I'm going to come right out and punch you all right in the nose with the first word that you need to know if you were interested in working for the federal government, and that is bureaucracy. I say this tongue-in-cheek. This is not necessarily meant to be critical, but it's reality. If you would like to work for the federal government or the Department of Defense, you need to understand that you're going to be going to work in a multi-layered, large organization that has extensive administrative expectations and tasks that you're asked to do on a regular basis. Many of these tasks are redundant, and there are times that you will question the logic, the rational nature of some of the things that you're asked to do in an organization like this. It's just the way it is. And so what I have found is that it's very important to develop what I consider to be a cultural competence around being able to navigate in an organization like this. It's not uncommon to develop a sense of irritation or annoyance with some of the things that you're asked to do at times. And I'll give you an example. One of the tasks I have the pleasure of doing once every 2 weeks is my time card. This is in a system called ATAPS, and there are hundreds of acronyms, and I will not be able to tell you what each of them stands for, but ATAPS is a time and accounting system. It's basically like filling out a time card. There's a little gnat. You have to go into a computer system and fill in the hours that you are at work, any hours that you may have taken some leave, any hours that may have been a federal holiday, etc. And you have to submit that once every 2 weeks. In addition, you have a separate system. It's also another time and accounting system, but in this system, which is called DMRS-I, and that is, again, not the acronym is escapes me. I'm not sure what it stands for, but DMRS-I is a system in which you account for what you do during the time that you are at work. So you will enter administrative codes for things like direct patient care, indirect patient care, attendance of meetings, things of this nature. So this is one small example of what I consider to be a redundant system. But there are many, many layers of these kinds of administrative tasks that are just part and parcel of working for a large organization like this. And my point about developing a cultural competence, being able to navigate a system like this, is that you have to learn how to not let the stuff get under your skin, basically. My response typically when I'm asked to do yet another thing that I find questionable in terms of logic is fine, no problem, consider it done. I do believe you have to develop an attitude that is a can-do attitude and no problem attitude. You'll have that shortly, no problem, things of that nature. The folks that I think don't do well in these systems are people who need to express their irritation about these things or push back about these things, and that just is not going to work well. And I think it will make for just an inappropriate career choice for somebody who tends to react to things like that. So I just wanted to come right out front and talk a little bit about some of that stuff, because I think you need to understand that going to work for a large federal organization is going to involve some of these kinds of things. And I think it's something that you need to be aware of before you go any further. All right. So let's shift gears. Let's talk a little bit about some of the options. So if you've decided that you want to go to work for the federal government, you have many, many career path options. And just within the area of behavioral health, some of the jobs that I have seen, run across, been told about, heard about, include working in inpatient settings. Many of the, many of the military hospitals, so they're called MTFs, Military Treatment Facility is MTF. Many of the MTFs have inpatient psychiatric floors or wards. And so there are civilians that are employed on those inpatient wards. So that is one option. Traditional specialty care is an outpatient behavioral health clinic. So just typical outpatient behavioral health services like assessment and therapy, definitely civilians in those locations. There are positions that I've seen posted for psychologist jobs who are just involved in personnel selection, for example, with the State Department or the FBI. Those jobs I've seen quite a bit. There are many jobs within the federal prison system. And those jobs, believe it or not, sometimes pay a little higher, probably due to the risks involved in working in the prison system. There are jobs available in substance abuse treatment organizations. I know at Fort Carson, where I'm located, we have a substance abuse treatment program, and there are a variety of different behavioral health providers within that program. Across the DoD, there are also inpatient substance abuse treatment programs, and those are also available to civilian providers. There are child and family behavioral health systems within the DoD. There are developmental pediatric clinics within the DoD, just a few of them. One of them is located in Seattle, outside of Tacoma. Madigan Army Medical Center has a developmental pediatrics clinic, and I have seen psychologist positions posted for that clinic. They do a lot of autism evaluation. And then lastly, primary care behavioral health, which is what I'm going to spend the majority of our time talking about tonight. It's a position that I'm in. Primary care behavioral health is a program that started probably around 10 to 12 years ago, initiated within the Air Force and then kind of fanned out across the other branches of service. And we'll get into a little bit more detail about what that's all about. All right. So when we talk about a multi-layered system, I created this slide to give you a sense of how many layers there are above my primary care behavioral health name. So with the overarching umbrella of the Department of Defense, Below that, we have Defense Health Agency, DHA. That is the system, the organization that oversees all of the medical and dental care that goes on throughout the DoD. I work within the Department of the Army at Fort Carson, and within Fort Carson, I work within the system called MEDAC, which is an acronym for Medical and Dental Activity. Within MEDAC, I work within the hospital, which is Evans Army Community Hospital. We have 70,000 enrollees in our hospital. This is a big Army base, big Army post. Fort Carson is about 65 to 75,000 people at any given time, depending on how many folks are deployed. Our enrollees refer to the number of soldiers that are enrolled, but also family members and retirees that are enrolled with our hospital as their primary location for care. And within Fort Carson, besides the hospital, we also have several outlying clinics spread across the post. The Department of Behavioral Health is not located in the hospital. It's on a different part of Fort Carson. And then not every single unit, but many of the active duty units have embedded behavioral health providers within their unit. So there are multi-layers of behavioral health services throughout Fort Carson. I work within the Department of Primary Care in the hospital, and I am a part of a team of what used to be about 6 behavioral health care consultants, and recently we've had 2 folks left, so we've got 2 open positions at this point, which may be some good news to some folks listening tonight. All right. So let's talk a little bit about primary care behavioral health. So primary care behavioral health, like I said, was a program that was developed within the DoD about 10 to 15 years ago. Some of the names of the founders of this program, Chris Hunter, who is currently head of DHA for behavioral health, and Ann Dobmeyer. And these folks have authored a book on primary care behavioral health, which I've used in a class that I have taught at University of Denver. So they have both published extensively in the area of primary care behavioral health, and I actually had the pleasure and the good fortune of having Ann Dobmeyer be one of my trainers when I went through training for this program. So these are great folks. They have collected a tremendous amount of research to put this program together. There are primary care behavioral health consultants throughout the DoD, all over the United States, in many, not every single military installation, but most military installations, Army, Navy, and Air Force. And then overseas as well. So places like Germany, Japan, Hawaii, other places. So primary care behavioral health consultants are many times psychologists, but they also can be social workers or marriage and family therapists. They do hire from other disciplines as well. There is a formal training program that lasts a few months for even licensed professionals who've been in practice for 20 years, because the model is specific. The documentation required in the medical record is very specific. So there is a pretty thorough training program that I went through and many of my colleagues went through. There's a structured progression through that training program. So it starts with typically, well, in non-COVID times, it was an in-residence 2-week training in San Antonio for me. Other folks have gone to Washington, D.C. for their training. And you do a lot of role playing and demonstration of your skills, and you are graded. And if you do well, you pass your training. There is level 1 training, level 2 training, and basically level 2 training just basically entails you getting back into your specific clinic, doing trainings for the physicians or the other medical providers that you work with, things of that nature, and then kind of building a clinic for yourself. So building a stream of referrals and things like that. So this position entails working within a medical clinic. So my office specifically is in the pediatric clinic at Evans Hospital in Fort Carson. I started there in 2012, and I probably spent the first year getting to know all of the medical providers that I work with, as well as the nursing staff, the front desk, and other administrative staff, and basically learning from them, but as well also teaching them how to use my service. And that process took, a number of months for people to get comfortable with me, understand what it was they could refer to me for, what kinds of things I did. And the development of that kind of rapport and collaborative working relationship with folks was instrumental in this program being successful within my clinic, but also at Evans in general. And it's important, I think, too, to mention that if you're thinking of a career in primary care behavioral health, that you have some exposure to health psychology topics. There are a number of pathways through which physicians and mid-level providers can refer to you. And you want them to be thinking not only about depression and anxiety, those are the obvious reasons, but also other things that patients need perhaps some behavioral intervention around. And we'll talk about some of those specifics in a minute. So it's important that if you're thinking about this as a career path, that you have some background and some knowledge of different types of health conditions, and then also really good clinical skills and good clinical judgment. It's hard to know, I think, exactly what you're looking at the first 5 or 10 times that you see it. But probably after the 20th time you've seen something present, it gets a little easier to recognize, and you kind of know where it fits in with regard to other things that you've seen, worked with, treated. So clinical skills and clinical judgment are a huge part of this job. And part of the reason for that is that you have such a brief amount of time with patients. And we'll talk about that here more in just a minute. All right, any questions so far? I want to pause here. Okay. All right. So in primary care behavioral health, we think of ourselves as training physicians, nurse practitioners, physician's assistants. We train them to use behavioral health services for a variety of different patient concerns, not just your run-of-the-mill depression, anxiety, ADHD. When I initially took this job in 2012, I had no idea what I was getting myself into. When I was asked, oh, what are you going to be doing in your new job at, with the Army? And I thought to myself, well, I knew I was going to work in a pediatric clinic. And so I assumed I was probably going to be doing a lot of ADHD evaluations. And I certainly do some of those, but the variety and the just the breadth of clinical situations, things that present in primary care is astounding. And I love it. And I tell you about that because I had no idea, but I have seen it all in pediatrics and in the family medicine clinic that I also consult for. So what I will tell you is that everything shows up first in primary care. That's pretty much where it shows up. So it's a great place to work if you want good experience, but important that you have some before you come as well. Just to give you a sense of some of the pathways that we're involved in working collaboratively with physicians. We work with a lot of chronic pain patients, and we have very specific protocols that we use with these patients that we get training on. The training is excellent in my job. They will put us through typically a 10 or 12-week training protocol to learn basically a set of strategies and modules that you can teach to patients. Chronic pain is one of those modules that we have gone through training for, and it's a great pathway. So we are doing a brief CBT. It's brief CBT for chronic pain, basically, is what we're doing with these patients. And this is really in an effort to, along with the push to get patients off of opioid medications. Several years ago, we realized we had a pretty big problem in the DoD with a number of patients that we had on very high levels of opioid medications. And that situation has been improved tremendously over the last 5 to 7 years. And I've been involved in that, and it's been really interesting. Some of those patients are incredibly challenging, but it has been a very rewarding process to be a part of. We also get involved a lot with diabetes management patients. Believe it or not, lots of people with diabetes are not super compliant with what their doctors ask them to do. So oftentimes we're asked to get involved with patients who perhaps have some level of depression or other kind of mental health issue going on that really undermines their motivation or their willingness to engage in good self-care and follow doctor's instructions or take the medications that they're supposed to take. So we get involved in diabetes management pretty frequently. Obesity is another pathway. We have a weight management program in our hospital, and we also have a bariatric surgery program in our hospital. So for any patient who is anywhere from overweight to severely obese, we have a program for them, and behavioral health is heavily involved in both of those programs. Just in terms of the behavioral components with goal setting and monitoring of behaviors, both eating and exercise. We do a lot of motivational interviewing with these patients. So this is another great way that we're involved with medical patients. And then lastly, insomnia. We have been trained in both CBT for insomnia and BBTI, which is brief behavioral treatment for insomnia. And I see a large number of patients with sleep issues. We usually start with sleep hygiene recommendations, but beyond that, we have a couple of different modules that we can offer to patients and put them through the protocol, and most patients do really well. So the treatment that we offer is all evidence-based. There are many handouts that go along with our appointments with patients. So we're an official and a pretty helpful part of primary care service. And it's a pretty enjoyable place to work. It's pretty intellectually stimulating to spend your days with people in other disciplines, treating patients in a multidisciplinary fashion. So I really enjoy it, and I would highly recommend it to anybody who's interested. A few more points. In terms of the rationale for primary care behavioral health, the reason that this program was created to begin with was two-pronged. Number one, we have to meet patients where they're showing up, and patients initially show up in primary care. The average number of complaints in a 15-minute primary care appointment is 3, and the number of behavioral health issues seen by the average family medicine doctor in any given day is many. There is often a behavioral health component to just about every appointment that comes through the door, whether it's a medical condition that has a behavioral health component or a lifestyle or behavioral component, or whether it's just a straight up somebody coming in with depression who wants to talk about getting on an SSRI. So we are there because we are needed. The other point is that the reason we need to be there is because the research indicates that about 60% of patients who are given a referral for behavioral health and then asked to leave primary care and go find a behavioral health provider, about 60% of those patients actually never end up following up. So the genius in placing us in primary care is obvious, and it has gone very, very well. So for a typical primary care behavioral health consultant, we make ourselves available to all of the medical providers throughout the day. It's almost as if the medical providers are our clients. Of course, the patients are the patients, and we are there to help the patients, but we are available to the medical providers. They are instructed that they may interrupt us. They may knock on our doors. We wear walkie-talkies called Voceras during the day. We can be paged on those at any point in time during the day. So you can probably start to see how this looks a little different than traditional psychotherapy. We do not hold out that we are doing therapy. We are doing brief assessment and brief intervention from a behavioral health perspective. But the line is very clear that we are not engaging in psychotherapy with our patients. So our appointments are anywhere from a 10-minute brief introduction and description of what we do to a 30-minute, intervention for insomnia. Maybe that third appointment is a 30-minute appointment because we're scoring their sleep log and we're going through recommendations for the next 2 weeks. So those appointments vary, 10 to 30 minutes. And then there's quite a bit of documentation that goes along with it too, and we'll talk more about that in just a second. This is based on about a 4-session model. We're asked to keep the vast majority of our patients at or below 4 sessions total. And the mean median number of patients, the mean or median number of appointments that each patient has is actually 1. Most of our patients we just see 1 time. But some of them we see 2 or 3 or 4 times, and a very small percentage of patients I've seen longer than that, particularly during the pandemic with folks being stuck at home and being comfortable talking on the phone. I have a number of patients now that I've seen more than 4 times over the last few months because of these circumstances. And we just tend to focus on behavioral intervention, and that can be anything from teaching deep breathing or another relaxation skill to teaching about lifestyle and health-related behaviors to go along with improvement of health or treatment of a medical condition, and then symptom management. So we tend to be pretty focused and kind of brief and behaviorally oriented, I would say. All right, so before we move on, that's about the gist of what I was gonna say about the primary care behavioral health role. And so I'd be happy to take any questions that anybody might have about what that looks like. Is anybody out there doing primary care behavioral health, either in an externship placement, an internship, or postdoc?
Like it. But we did have a question in the chat for you.
Okay.
And Edward is curious about the early career path to primary care behavioral health from internship through licensure. Can someone attend an internship, DoD or elsewhere, and be hired pre-licensure while accruing additional hours under supervision?
It's a great question, and I'm going to talk about that next. So good timing.
Yay, segues.
Yes, thank you. Appreciate it. All right, so let's talk about the hiring path. Okay, so if you don't already know, usajobs.gov is the place to find position postings for any federal government civilian position that you may be interested in. usajobs.gov includes not just DoD, but also VA, Bureau of Prisons, and Indian Health Service jobs. So there are a number of position postings on there. I did a brief search a couple of days ago. I just plugged in psychologist. They just ask you for a descriptor. It's actually a very user-friendly site. I plugged in psychologist. I didn't put any other filters in there in terms of location. I came up with 236 positions in the US and overseas. So that's a high number of position openings at this point, but those are really a lot of different types of positions. So you really have to get in there and fish around and read the position description. Some of them are also, it looks to me like duplicated either they're reposted or something. I'm not sure, but you'll see duplicates in there as well. So the 236 is maybe not an accurate number of actual positions that are open at the moment. I know at Fort Carson, to answer your question more directly, Edward, we currently are working on creating a developmental position for a pre-licensed person. We have never done this before. We have a medical director currently who is very enthusiastic about creation of developmental positions, and she has done so for a nurse practitioner in our family medicine clinic. So we're hopeful that we are actually going to be able to make this happen. But it may be one of the first positions of its kind. Historically, all of the PCBH positions have required that you be licensed in order to apply. But like I said, it could be an LPC license or a social work license or a psychologist license, depending on the location. At Fort Carson, we're all licensed psychologists, but that is not the case everywhere around the DoD. And just to tell you a little bit about what you can expect. So what are we talking about here? So when you go to get hired by the federal government, you are applying for a government services position. So all of these things have ratings, scales, levels, and steps. So a psychologist is a licensed psychologist is a GS-13 position, almost uniformly. But there are 10 steps that you can go in at, depending on your background experience, your previous salary, those kinds of things are what factor into what step you'll be hired at. A GS-13 step 1 is the lowest level GS-13 position. That starts around $89,000 or $90,000 a year, I think. And that is base salary, and that does not include things like recruitment bonuses, which do exist in the federal government, or retention bonuses, which is what your recruitment bonus turns into if you do a good job. And locality pay is another factor. So again, going back to multi-layers of things, there are multi-layers to salary. The GS-13 goes all the way up to about $132,000. That's at a step 10. And I'm not sure what exactly, but I did see a position description that included that range. So your salary ultimately is going to depend on where you're working. So at Fort Carson, we have a certain locality pay based on cost of living in Colorado Springs. But in Denver, that same job would have a higher locality pay because the cost of living there is higher, and I would be making a little more money in the same job if I was working and living in Denver. But your pay is also based on your number of years of experience, your years on the job, because as you stay in your job, every few years you will get a step increase automatically. And so there are a number of factors that kind of go into the salary, but I wanted to give you guys a sense of what the starting salaries are for licensed psychologists, because in my experience, the salaries here are a good 20% or more higher than just about anything else you would find in this area. So if I look around at other position postings in Denver and Colorado Springs, a licensed psychologist starting salary sometimes is down in the 60,000s, maybe up to 80,000 a year. So working for the federal government represents, I think, a significant increase in starting salary. So I think that's one of the pluses. So going back to usajobs.gov, one of the things that you can go ahead and do ahead of time, if you just want to go and peruse job postings, maybe you're not ready to apply yet, but you could go ahead and go in and create your profile, and you could start uploading some of your documents. These are things like your transcripts, your CV, your license, because usajobs.gov saves all of those materials, and then you can always just go back and like copy and paste them when you go apply. So applying for multiple jobs within this system is pretty user-friendly. And then lastly, and this is a very important point, the way that So another acronym is PAS, P-A-S. This is the organization that is instrumental in the hiring actions for new people. So the PAS, and I don't know what that stands for. I think it's personnel acquisition something, I'm not sure. They basically put people's resumes through some kind of algorithm. And if your CV does not match the keywords in the job description, your resume will not be selected for interview. And this is hard to explain because it's kind of like, you know, it's like behind the curtain, like in the Wizard of Oz, right? Like you're not really sure what's going on back there. Nope, none of us really know how this works. And when I was hired, basically the administrative assistant in the pediatric clinic called me, had me fix my resume, and then resubmit it so that it would be selected. And sometimes that's how these things work. And I was very thankful and appreciative to her for that, because I didn't know what I was doing. I had never applied to a federal position before, but there's a little bit of madness to this process, and it's important to understand. So there's another website that I heard about over the last week called FastClass. Does anybody know about FastClass? Okay, FASCLASS. I tried to look at it and I got a warning that it wasn't a legitimate website, but I know that there is a legitimate FastClass website out there, and it provides job descriptions for just about any position in the DoD. And that is a good way to help you build your CV to be ready for application for a DoD position. So take a look around. Don't open anything that you shouldn't open, but check that out and see what you can find. All right. And then just in terms of other ways to get in and get where you'd like to go, there are a variety of internships out there that are available. You guys probably know about a lot of those. Some of these, most of these are commissioned placements, I think. There are also postdoc placements available. And then there are also pathways through public health service. And I don't know how much you guys know about public health service, but if you are commission eligible, meaning you are young enough to be commissioned, and I think you can't be older than like 42, then public health service is another option. We actually have a number of public health service officers in the Department of Behavioral Health at Fort Carson. The current chief is a public health service officer. So it is another branch of service. Some folks really have never heard of it. I had never heard of it until I was in my mid-30s. I had a patient who was going to work for the public health service. I was like, oh, what's that? But it's just another branch of service. It's another pathway, but it is commissioned service. Okay. And lastly, I know this doesn't need to be said, but as with any job, connections matter. So getting an externship in a military facility is helpful. That will help you get a connection. We'll talk some more about some more things that you can be doing now. Externship placements, practicum placements, internships in VAs, or I did a practicum placement in a VA at one point in my training when I was working on my PsyD. Any work opportunity, even a volunteer position. Our hospital has volunteers through the Red Cross. Many hospitals do. So any way that you can get your foot in the door and meet the people who may be recommending you for a job would be really encouraged. Being involved with this, Division 19, I think is very smart. Going to APA, networking with some of the folks if you can. There's another organization called CFHA, Collaborative Family Healthcare Association. I don't know how many of you know about this organization, but this is an international organization that is based on primary care behavioral health services, so integrated behavioral health into medical settings. I have presented at CFHA a couple of times. Most recently this past October, and it is a place where the bigwigs from Washington, D.C. in the primary care behavioral health organization come to network. So it's a great organization to belong to as well. And if you can't get your foot in the door in a military installation or a VA setting, then just getting experience with military populations in your client base, I think, is important. If you get into an interview at some point in one of these positions, they're going to ask you about your experience with military personnel and how many of you worked with and what did you learn from that. And being able to talk in a manner that conveys that you are culturally competent in terms of working with a military population is going to be very important to getting hired. And then any research opportunities you have, obviously, being able to, look into the research in this area, trying to find out who and where those folks are and what opportunities there might be to participate in research projects. Okay. So finally, 6:40, I'm watching the time. I want to briefly go through a list of pros and cons that I created, and this is absolutely just my opinion. You will notice that my list is probably very financially weighted. And the reason for that is because I've got one child in college and another one getting to start, and I'm 13, how many years away from, I'm 13 years away from retirement. Okay, I just shared my age. That's okay. So when you get to my age, you start thinking a lot about money because you realize you don't want to work until you're dead. You want to be able to retire. And the lovely thing about working for the federal government is that you have an opportunity to retire and actually have a decent lifestyle. So in terms of my benefits, my list of benefits in terms of working for government service, first and foremost, the opportunity to serve those who serve. I don't want this to go unsaid this evening. I feel a tremendous amount of pride and a little bit patriotic about working with the military population. I am not a person who would have gone into the military myself. However, I do feel a little bit of pride about working with this population. It makes me feel good that I am available and there to serve these families that I work with. And I, several times a week, will say to a mom, for example, that I have on the phone, look, you call me back anytime. I am here for you. This is my tax dollars, your tax dollars, but my job is here because I am here to serve you, and you may access me for whatever reason you wish. So I feel very good. I have a lot of altruistic, positive feelings about working with this population and having the job that I have. So first and foremost, I want to make that clear. But secondly, the pay, making more money than much more money than I would be able to be making in private practice, certainly. And then really, if I was working at Children's Hospital in Denver, I'd probably be making maybe 2/3 of what I'm making here. So it's a big deal. The more you make, the more you can save, and the more realistic retirement becomes, right? But not only the pay, your salary is just one piece of this benefits package, which includes many, many things. I just didn't go into this much detail, but when I look at my pay stub and I look at the list of government contributions to my benefits and my pay, it's extensive. They pay they pay the lion's share of my health insurance premium. So I pay a very, very small amount of money for my health insurance. The federal government pays the bulk of my premium. They pay toward my retirement. They pay into a program called FERS, Federal Employment Retirement System, which is basically a pension. I contribute about, $20 or $30 a pay period into that program. The federal government contributes somewhere around $500 or $600 a pay period into that program for me. And that is what's going to be my pension when I retire. And then there is a separate retirement system called TSP, Thrift Savings Plan, which is like a 401k. You contribute to that as well. Other benefits, your time off, it's pretty generous. For the first 3 years that you work for the federal government, it's minimal. You earn 4 hours of annual leave per pay period and 4 hours of sick leave per pay period. But after you've worked there for 3 years, they bump your annual leave up to 6 hours per pay period. After you've been there for 15 years, they bump that up to 8 hours per pay period. So essentially, you're getting a day off every 2 weeks. Seems a little ridiculous, but the benefits, the time off is very, very generous, which really just means that you're able to achieve a fairly pleasant work-life balance. I work very hard when I'm at work, and I go to work at 7:30 in the morning and I leave at 4 or 4:30 in the afternoon. I work very hard during the hours that I'm there, but when I'm not at work, I'm not working, and I'm gardening, or I'm riding my bicycle, or this weekend we're going camping. So I have a very pleasant work-life balance, and so I think that is a huge benefit of working for a system like this. Also, you have the ability to move around the system and maintain your same GS level and step level if you move. So if I were to leave my position and take a similar job in Japan, my pay would probably change a little bit different. My pay would change a little bit because the locality would be different, the locality pay based on cost of living in that location, but they would never be able to take me down a step. I would have to be hired in at the same step level that I work now. So there are a lot of safeguards built into working for the federal government. The list is very, very long. I could go on and on and on, but there are just a number of security safety net programs. For example, you can take a loan from your TSP and pay it back. So if you ever ran into trouble or needed money, or and then not to mention that just the job security is very, very good working with the federal government. Okay, the downside, let's talk about it. I'm a very reality-based person, so I wanna make sure you understand. This kind of a job is not for everyone. I mentioned, back to that first screen, this is your new vocabulary word if you didn't know it already. This is a big bureaucracy, and there is a lot of pain in the keister kind of things that you're asked to do in working with this organization. But in my opinion, I'm happy to do all of it because I feel really good about where I'm at. Also, the hiring process can be a bit tedious. I will share with you that I applied for the job I have now in March of 2012, and I started my job in December. So it was a 9-month process from start to finish. So that gives you a sense of how tedious the hiring process can be. I've gone over a number of administrative expectations. One of the things I have not mentioned yet is the online training du jour, which is my way of dealing with a sense of humor at the endless number of online trainings that we're asked to do. Slideshows, take a quiz. There are times I've taken the quiz 3 times, I still haven't passed, I'm banging my head on the desk. It's like there are some things that you're asked to do that they get pretty tedious, but you get through it. And then lastly, I want to mention that honestly, I do think that there's a risk of boredom with a job like this, because many of the things that we're doing, particularly in terms of entering documentation into the medical record, that are very repetitive. Many of my notes are very similar. There are small details that are different, but the coding, the diagnostic process, the disposition section, all the things on the front page in terms of the administrative stuff. So the medical documentation is repetitive, and I think that this is a job that if you need a lot of just like multiple fingers and multiple pies during the day. I think of like the person who's in private practice, who's also a college professor, who also has a side business for, doing like motivational speaking or something. Those folks who have like 6 jobs and they kind of have to be moving all the time. This isn't one of those jobs. But what I will say is I do believe you have the ability to create intellectual stimulation for yourself if you have good management, and I do. And so I'm usually working on a project or two. Like I was saying earlier, I have 1 or 2 students from DU externing with me at all times. I'm usually working on some kind of a project, either creation of a pathway. A couple of years ago, I went to Madigan Army Medical Center and got some training on an autism screening tool called the STAT. And so then we developed a pathway for screening 2 to 3-year-olds in the pediatric clinic for autism. So I'm usually working on a project, in addition to my student supervision, that kind of keep me, busy and keep me interested and enjoying my job. So I'm going to stop there. And I am open to any questions that anybody might have. I spoke a lot longer than I intended to, but I hope this information was helpful.
So you have a lot of questions in the chat. There's a couple about your presentation, and there are questions we have for you that people wanted to know upon registering. So I'll start with the ones that are directly in reaction to your presentation. And Deja wants to know, do you often see patients with conditions that you are unfamiliar with, and how do you usually address this?
So this is going to sound a little arrogant, but I don't see much of anything that I don't recognize or know what to do with anymore. I've been licensed since 2002. And what I will tell you is that early on in my career, when I was a student and just newly licensed, I frequently had the sense that I had no idea what I was looking at and no idea what to do with the person sitting in front of me. That was a very common experience. Once you've been doing this for 20 years, it just doesn't happen to you anymore. And I think the reason for that is if you continue to read and you practice in a location where you're getting a large volume of patients and a wide breadth of clinical presentations, there's just only so many things out there, and most things fit into one of the pots that you have kind of seen before. I don't know how else to answer that question, but clinical experience and clinical acumen is actually a real thing. You will also get there, not to worry. I find it actually pretty satisfying because you do become a subject matter expert in your clinic at a certain point. People will come to you and ask you questions, and you just don't hear much of anything that you have not heard before after a certain point of time being in practice. But we do see some interesting things, but they usually fit into one of the categories we know to put them
in. Leslie wanted to know, since you only see patients from about 1 to 4 times, are you referring them out to other mental health providers?
Yes, very frequently. So one of the jobs I have is to triage. So I am frequently triaging cases, and I will tell you, one of the questions I always ask if I'm in an interview with a new patient for the first time I've never seen before is there a history of trauma? If there is a history of trauma, I am not treating that patient in primary care. It's just one example, but we refer all patients with PTSD, anybody who has a history of trauma, who needs a trauma-informed therapy, we refer all those off post. We are not going to attempt to do CPT or EMDR in primary care. We just don't have the time. We're interrupted too frequently. It's just not appropriate.
Priscilla wanted to know if there's other opportunity, or are there opportunities to train to be a psychologist who can prescribe while working in the DoD?
Good question. 2 of my colleagues have been through prescriber training, would love to find a supervisor that would allow them to prescribe under their license. Neither one of them have had any luck thus far. So at Fort Carson, I've got 2 colleagues who have just been continuously running up against a brick wall on that issue. I do know that there are a few prescribing psychologists in the DoD. I have not, I saw one speak actually when I was a student, and that was a long time ago. I think he was one of the first guys that went through the prescriber training back in the late 90s. So I know they exist, I know they're out there, but I think it's really hit or miss depending on where you're at. And I think you just have to get lucky in terms of finding a psychiatrist who's going to sit still long enough, meaning be at that post long enough to be able to supervise you.
She also wanted to know, how might we be able to increase the number of sessions a client has and follow up on care, possibly with a behavioral health follow-up with each primary care medical appointment?
So I have a really good sense within my first interview with a patient whether I'm going to keep them and follow them myself because I think we can take care of the issue within 3 or 4 sessions, or whether I'm going to refer them out. That's pretty straightforward for me. It's pretty black and white. I keep things that are obvious. I keep mild anxiety that I think will respond well to brief intervention with, teaching relaxation strategies, providing information and education. And these are people who don't have a very long history of the symptoms. They don't have other issues. They're highly functional in school, in their jobs. You have a really good sense of who you're keeping in primary care and who you're not keeping in primary care. So for those folks who need to be in therapy, who I know are going to need to be in therapy more than 3 or 4 appointments, we're going to refer all of those. And I will often provide resources. So I serve as a little bit of a case manager. Here are the 3 people I want you to call. Here are their phone numbers. And then I will often set up a phone call, to call them back the following week, just to make sure they got connected to services. So I hope I answered your question, but I just have a certain way that I go about kind of triaging how to handle that, and it goes fine.
Leslie wanted to know, as a graduate student, what practicums and internships should I be focusing on while I'm in school as a preparation for working as a primary care behavioral health provider?
Great. Any VA, any MTF, military base, any medical setting, even if you can, if you can find a setting like an OBGYN clinic somewhere who's willing to let you come in and teach, a little 20-minute blurb on postpartum depression once a week or whatever. Any medical setting, any VA, any military treatment facility, I would say would be great. I don't know what your options are. If those are not options, then I would say if you can get into just an outpatient clinic in a community that has a large military population and try to get some military clients, that's also helpful.
Okay, now we just have some questions from when people registered that people wanted to know. So we've already answered a couple of them, but what training experiences prepared you for working in these settings?
That's a really good question. I think I got really lucky. When I was hired, this was a brand new program. They needed 6 bodies to fill these positions when I got hired. So I think the odds were in my favor. I had child experience, and they had one position they needed to fill for a pediatric clinic. So I think they were like, bingo, here's our child person. I had done an extensive practicum my 3rd year in my training at a child site. And then I had also done 6 months of training at a child site in my internship. So I had extensive child experience. And then I was in private practice for 10 years prior to taking this position in a suburban area where I just mostly saw kids and families. So I think that was a big part of the reason. I think another part was that I was sharing before we started with Sarah that I was a military wife for 10 years. And so I had some exposure to the military. And it was actually one of the questions I was asked in my interview: what experience have you had with the military population? And I was like, well, I was a military wife for 10 years. Does that count? I didn't say that. But I think just having been a part of the lifestyle for some time helped them feel comfortable that I knew a little bit, in terms of what it was like to be a family member or the lifestyle that military folks are engaged in and what they're dealing with. So I think those are some of the things that helped.
As a follow-up to that, someone wanted to know, what training experiences do you wish you could have had more of to help with being prepared for this setting?
I wish that I had been able to work in a pediatric office, because I would have loved to be a bit more familiar with the workflow in a pediatric clinic. I had some sense of it because, I had kids and I took them to the pediatrician, but this clinic that I work in is huge. I think we have 15 pediatricians, nurse practitioners, and PAs in our clinic. We have like 30 plus nursing staff. So it's a really big, really busy clinic. And during non-pandemic times, it gets pretty crazy in there. Right now, we're not seeing very many patients, just babies, just well visits. So I would have loved to have been able to have some medical clinic experience, whatever that looked like, volunteer or otherwise. So I think any experience or time you can get in a medical clinic is beneficial.
Okay. Sorry if you can hear my dog. Um, Someone is wondering, how can we use integrated behavioral health in our positions as mental health providers to draw attention to issues of discrimination, specifically some systemic domains like EO, family advocacy, SAPR, or SHARP, and retaliation and unhealthy military personnel where it may emerge in the service?
Well, that's an interesting question. I have a lot of thoughts about that. One example that comes to mind for me is that part of my position description is that I am there to provide staff care, which seems a little counterintuitive probably to you all because it brings up the whole issue of dual relationships, right? But the military doesn't really seem to care that much about those things sometimes. So I'm often called upon to engage with a staff member who is either struggling in a management relationship or coworker relationship. And oftentimes those kinds of tasks that I'm asked to attend to have an element of discrimination or harassment. I frequently have to put staff members in contact with either Equal Opportunity Office or Employee Assistance Programs or the union. The nursing staff are all union members, which is another interesting organization. So our staff members have a lot of resources available to them, and oftentimes they are not aware of those resources. So that's the example that comes to mind for me. I'm not sure that answers your question, but I think being available to staff and being aware of the resources that are available to everyone around there. I've had plenty of, cases that I've had to involve the SHARP office on. I've had many cases I've had to involve family advocacy on. So I think just being aware of your reporting obligations and being aware of the resources is incredibly important, obviously. And it's pretty frequently that I'm involving those other organizations. And it's, they know who we are, we know who they are. We all communicate very well together when we need to. So I hope that answers your question.
Also, someone was wondering, what are barriers to providing and patients receiving mental and physical health care, and how can we address this?
Well, I guess the nice thing about working in this system is it's an enclosed healthcare system. So anybody who wants care is going to get care. They don't have to pay. They don't have a copay. There aren't a lot of barriers for these folks. The main barrier is the stigma, I think, associated with asking for behavioral health services, which is one of the main reasons that we are integrated into the primary care clinics, because we wanted to really try to decrease that stigma. If a patient makes a medical appointment with their primary care provider, their physician, for feeling tired, right? That primary care physician is attuned enough to know that perhaps there could be a component of depression going on. They come down the hall and get us. We go in the room. That patient didn't have to make a behavioral health appointment. We then can engage that patient in care. We can see that person in primary care, and we've really increased that patient's access to care. It's really the basis of the model. I know I'm not answering your question, but I I think that this is one of the real benefits to this completely enclosed medical system that we have in the DoD, because these patients have ready access to services of many, many kinds just at their fingertips, and there are no financial barriers to those. If we have to send patients off post for therapy, there is sometimes a copay. TRICARE does require a copay for some kinds of services. So that can be a barrier to care. So yeah, I don't, in the financial piece, I'm not really sure how to remedy. That kind of is what it is. But anything else on that?
There's somewhat of a follow-up question. What are your patients' typical attitudes or views regarding mental health services? Example, is there stigma regarding mental health issues according to your observations, and how do you handle that?
Yes, absolutely. I sort of feel like I already answered that question, but I will just say a little more on that. There is definitely a stigma against seeking behavioral health services, more so in the military, I think, than in the general population. Many soldiers seem to be afraid that if they seek mental health services, that it's going to have a negative impact on their career. And that really couldn't be further from the truth. I think that there are certain units and certain leadership folks who can be a little bit more difficult with patients just about going to appointments in general. But you don't have to tell your leadership if you have a behavioral health appointment versus a physical appointment, and you just have to say you have an appointment, you know. Sometimes you have to show, you know, the appointment slip, but it just says this is with Dr. So-and-so at 4:00 or whatever. So the medical record is private. Obviously, nobody can go into the computer and go into your medical record without that being a major HIPAA violation. So these patients have a lot of privacy, but still the stigma prevails. And I think a lot of soldiers avoid seeking behavioral health treatment, which again is one of the main reasons that we have behavioral health providers embedded and integrated into medical clinics and into their units, so that there's ready access, there's walk-in availability. We try to decrease all of those barriers as much as we can.
Okay, I think two more questions.
Okay.
Are there forensic psychology positions that you have seen in military hospitals?
Not in the military hospitals, more so in the prisons. When I think about forensic psychology, a couple of examples come to mind. So prison work comes to mind. If you work for the prisons, you do a bit of those evaluations of competency. That is one role that I think a forensic psychologist can play. And then also other areas in the legal realm, things like custody evaluation, things like that. That is really heavily, I think, staffed by private practice psychologists. Even military folks seeking divorce and custody of children have to go through a private attorney and then private psychological providers in the community who do those evaluations. I have not seen a lot of forensic psychology positions, definitely not in the hospital. There may be other things I'm not aware of, but nothing's coming to mind. I've never heard, so we don't interface with the JAG office a lot, the judge advocate, that's the legal realm in the military. We don't interface with them much, but I don't think they employ any mental health professionals over there. I just don't. If they do, I've never heard of it.
Great. And finally, what has been your experience with social justice, specifically as it relates to race and working in this position and working as a mental health provider for the DoD with colleagues and patients?
Well, let's see here. One of the things I guess I would like to say about that is that the military, the Army specifically, is a very diverse group of folks. I have worked with a number of people from different backgrounds, different races, religions, different countries. You know, we have American soldiers that we pull from all different parts of the world. So it's really interesting. I've worked with families from Africa. I've worked with families from Russia who are in the US military. So the opportunity, I think, to work with a very diverse group of folks is there, and it's great. I think on the downside, um, there is very little diversity amongst the providers. And I guess that's probably one of the things that I would like to address in response to that question. So we have 2 positions available at this point. Neither of them are posted. So if you go on usajobs.gov, they're not on there yet. We haven't posted anything yet. One of the primary care behavioral health consultants left about 6 weeks ago. The other one just gave notice on Friday. So my manager is working on those job postings. But one of the things that I would like to do with that is to kind of put out an invitation to developing a bit more of a diverse staff in terms of the behavioral health providers in our hospital. It's just not there. And then I guess, you know, because the soldier population is pretty diverse, our nursing staff population is very diverse, but the providers, the physicians, the nurse practitioners, not quite so much. So, you know, I think that there's definitely room to grow there as a staff, but it's really going to require, I think, putting some effort, you know, into really advertising that and requesting it as we post these positions. I guess lastly, I want to acknowledge that just, I'm sure like in any workplace situation, I definitely observe people who come from different parts of the country or different backgrounds. And I think, and I overhear, this is really, I probably shouldn't tell you this, but I sit in a location in my office where I'm right next to the nurses station, so I overhear a lot of conversations. And I don't mean to eavesdrop, but it just happens. I think I get it from my mom. So I overhear a lot of conversations that I am astounded by in terms of lack of education and information on racism, on systemic racism. I overhear conversations amongst folks who, you know, they'll talk politics at work, and it's really, and you're not supposed to. I mean, it's really clear that you're not supposed to air your politics in the workplace, right? But I'm astounded at the lack of awareness on this topic amongst some of the folks that we work with. And I will tell you that in the past, I have supported staff members who I believe have been discriminated against, and really tried to help, not trying to undermine management, but really trying to support staff members who I feel like need the support of the union or of the Equal Opportunity Office to have their voices heard. So there's a lot of work to do in our facility, just like there is everywhere else. And I don't know, it's interesting. I read on this topic a bit. I'm interested in it. I just finished reading White Fragility, which was pretty mind-blowing for me. Really liked and enjoyed that book. And if I had my wish, I would love to do some staff training in this area. And I don't know, I'm thinking about it. I don't know what to think, but I think I would blow that place up, actually, in terms of just blowing everybody's minds and creating a tremendous amount of, you know, just based on the conversations that I've overheard among staff, I think I'd blow that place up if I did one of those staff trainings. But that could be a good thing, right? So I don't know. I'm thinking about that. But great question. I appreciate it.
Does anyone have any other questions before we wrap up? Go ahead and unmute yourself or put in the chat, whatever works best.
I suppose I'm curious. Hi, Ed from Pacific University. I'm curious if you would recommend a commissioned position or a civilian position in the DoD.
Well, it all depends on what all you want to get yourself into, I guess. As a civilian, I enjoy my ability to live where I choose to live. I think I have a lot less structure than somebody who might go into a commissioned position. But if you're, here's the thing, like if you're a person who has reasonable physical fitness, because that is a thing, they're going to make you like exercise. You have to go through training and you have to meet certain requirements in terms of your physical fitness, right? So if you're a person of reasonable physical fitness who is willing to basically agree to have the government decide where you live and when you go there and when you leave there, those are the main things that come to mind, for me. Like, I think you have a lot less personal freedom. So for example, the physicians in my pediatric clinic who are active duty, commissioned officers, they are put on the call schedule and nobody cares if they had plans to go on vacation, right? So if you are a commissioned officer, if you are an enlisted person in the military, you do what you're told, and you have to be okay with that, because there is no, well, I'm sorry, I can't do call this weekend because we have vacation plans. They don't care. So it really depends on what you're willing to tolerate in terms of losing some personal freedoms. I'm just being honest. I think the opportunities for earning and then retiring and then going back and working as a civilian, then that's almost like double dipping. So some of the most, not that money's everything, because it's not, but honestly, the way the military works is you can do 20 years as an active duty military person, and then you can retire and receive a pension that is about, I want to say it's about half of what you were making. I don't know, I could be wrong. I didn't research that before we had this talk, but it's a significant amount of money. Like, you earn that salary as a pension for the rest of your life. I think it's about half of where you finish out. So if you retire as a colonel, you're probably making upwards of $150,000 to $175,000 a year. If you retire as a colonel, you receive about half of that per year as your pension. Maybe you're only 45 years old and you can go back to work in the hospital as a civilian physician and probably make around $200,000 to $250,000 a year for the next 20 years until you retire. So there are significant financial benefits to doing a 20-year career in the military, and then perhaps doing a civilian career. So it's a good question. There's lots to talk about there. I would highly encourage you to seek out others who have gone that path. I have a number of friends who live in this area, who I've worked with at work or whatever, who have chosen that path, and it's a very comfortable life. But you certainly give up quite a bit. The other thing to mention is if you're active duty, you can be deployed, right? So that's the other piece of it. You have to be willing to respond when the call comes, and potentially be placed in a really unsafe situation.
Thanks.
Are there any more questions?
Yeah, I just had one more quick question. Thank you so much for presenting tonight. What advice would you have I am definitely in the camp of this is one of the populations that I really wanted to work with, is the military population. And I'm getting towards the end of my first year in my PsyD program, so ideas starting to percolate for how I want my career direction to go. But I do also tend to be the person who would enjoy being in private practice and being a college professor and kind of like having my hands everywhere. I guess what would be the advice for kind of decide? My question is, I don't want to decide to do this, but only do it for 5-6 years and then do something else. Like, would you recommend sort of feeling like this should be a 10 to 15 career, or you can't kind of do this and something else? I hope my question makes sense.
It does make sense. And so it brings to mind for me a concept called the golden handcuffs. Have you ever heard that phrase?
No.
Okay. So once you've worked in the federal government for a certain period of time, and some would say that period is around maybe around 5 to 7 years, others would say maybe it's around 10 to 12 years. But once you've worked for the federal government for a certain period of time, there's a phrase that is used, and it's called the golden handcuffs. And the reason that we refer to that is because the level at which you accrue financial benefits, time off benefits, it would be very difficult for you to leave your position with the federal government and go find something with a similar salary. So I don't know if that helps you. I think the federal system is an excellent career path. And if you choose to go to work, let's say you're in your mid-20s, your early 30s, and you choose to go to work for the federal government, the longer you are in federal service, the larger that federal employee retirement system pension is building, right? The larger retirement you're going to have. So in some ways, you're much better off starting very young. And if you're willing to commission, maybe commissioning and being active duty for a period of time, and you don't have to do that forever. You can do that for 5 years, 3 years, 10 years, or 20. You can do it for however long you want. The longer you do it, the more the incentive, right? I think there are a number of things to consider here. And when you guys are in your 20s and your 30s, you have all the options. When I took my job with the federal government, I was 44 or 45 years old. So I was too old to commission. I don't think I would have anyhow, because I had kids in school and just that was not realistic for me. But I will have 20 years in federal service by the time I retire. And that's a good amount of time. There are many benefits associated with that. So I don't know how to advise you. I think this is a very personal decision.
Well, that's what I'm wondering, because I'll graduate, I should have my license by 30. Mm-hmm. And so when I think about this, I'm like, do I want to take the federal route right away, and just have that, like you just said, the more time you're there, the more incentive you have? Or do I, from like 30 to 40, kind of dabble in the private practice and all these other things and then do it? But it's hard to make decisions like that because you don't know what your life will be by then, right?
Right.
Circumstances will determine what you do with your life.
Sure. The other thing I'll mention is that there are some federal positions that have student loan payback programs. And so if you are a person who's acquiring student loans, it's also something to take into consideration.
Right. Yeah. Okay. Thank you. I appreciate it.
Sure.
Well, Dr. Fontaine, thank you so much. I think this has been really beneficial for everyone. And I just want to highlight that as we do these webinars, all of the work that gets put in by the presenter, by Sarah, who is our virtual project officer, and Keen as well, like, our presenters aren't getting paid on the side, and it's a lot of work to provide us with these educational opportunities. So really big thank you.
My pleasure.
We're going to have more in the future. So I think Sarah just put in the chat our social media pages. So follow those to stay in touch with us for more webinars like this, because this was extremely helpful. So thank you again, Dr. Fontaine. Thank you everyone for coming, and thank you, Sarah, for all your work. And with that, we'll say good night and keep in touch with us for more.
All right. Good luck to you guys. Thanks.
Thank you.